I'm Dr. Trevor Feinstein. I'm board certified in hematology and medical oncology and have been practicing for over 19 years. ITP is a disease of complex immune dysregulation. Severe bleeding occurs in 7 to 10% of adults, and bleeding is more frequent with lower platelet counts less than 20,000. Seen in a cross-sectional study of over 300 French patients and a systemic review of 147 clinical trials. Signs and symptoms of bleeding can vary. They can include petechiae and purpura, bleeding blisters and epistaxis, and our fear, intracranial hemorrhage. Patients with ITP have a fourfold higher rate of hospitalization for bleeding. Heavy menstruation can reduce a patient's quality of life, or may reduce a patient's quality of life. Though it may seem paradoxical, patients with ITP simultaneously have an increased rate of arterial and venous thromboembolic events. ITP goes beyond low platelets. It diminishes patients' quality of life in functional aspects and mental health. Let us review the I Wish survey. This was an online cross-sectional survey of patients with ITP. It had 1,500 patients and almost 500 hematologists or oncologists in 13 countries. The median duration of ITP was 5 years. Insights from the I Wish survey highlight the considerable functional challenges faced by ITP patients. Some of the highlights was 58% of patients had fatigue as the most frequent symptom at ITP diagnosis. This fatigue was severe. 75% of patients noted that the fatigue impacted their ability to perform daily tasks. 49% induced or had work reduction due to their fatigue. In regard to mental health, 58% of patients endorsed mild to severe depression. 82% of patients had anxiety about long-term side effects of treatment. Research indicates that ITP may be a prothromboembolic condition. Risk factors for thromboembolic events in ITP include ITP-related. We see an increased level of immature hyperactive platelets. We have the presence of prothrombotic microparticles and endothelial activation. They can be patient-related. Previous thrombosis, age greater than 60, cardiovascular risk factors such as atrial fibrillation, positive antiphospholipid antibodies, a positive ANA, surgery, immobility. And lastly, they can be treatment-related. Our corticosteroids, IVIG, splenectomy, or TPORAs can increase the risk for thromboembolic events. Many patients with ITP cycle through treatment options. In a study conducted with the Platelet Disorder Support Group, 50% of patients had changed treatment at least 4 times. Reasons cited were insufficient platelet response, reduced efficacy over time, and symptoms or side effects to treatment. And what this highlights is that there's a need for novel treatments for ITP. Now let's consider the disease pathophysiology and the multi-immune drivers of ITP. ITP is a disease of complex immune dysregulation. For a long time, it was felt to be B-cell mediated. B cells produce an abundance of antiplatelet autoantibodies, leading to destruction of platelets via phagocytosis by macrophages and impaired megakaryocytic thrombopoiesis. Immune dysregulation has been linked to systemic inflammation. Inflammation occurs via an imbalance of pro-inflammatory factors and dysregulation of T cells. This is further amplified by increased NLPR3 inflammasome expression in immune cells. Treatments designed to achieve multi-immune modulation aim to better address the complex immune dysregulation of ITP. In autoimmune conditions, BTK is central and plays a crucial role in immune cell functions. For example, when we look at B cells, BTK is involved in B cell differentiation and antibody production. In macrophages, BTK is involved in macrophages undergoing phagocytosis. And lastly, in the immune cells, that BTKs are involved with inflammasome activation.
Indication: WAYRILZ, rilzabrutinib, is indicated for the treatment of adult patients with persistent or chronic immune thrombocytopenia, ITP, who have had an insufficient response to a previous treatment. Important safety information: warnings and precautions. Serious infections. An increased risk of serious infections, including bacterial, viral, or fungal, can occur in patients treated with Bruton's tyrosine kinase, BTK inhibitors, including WAYRILZ. Fatal pneumonia occurred in one participant treated with WAYRILZ in the LUNA-3 trial. Other serious infections, one each, 0.8%, included COVID-19 infection, wound infection, urinary tract infection, and kidney abscess. Monitor patients for signs and symptoms of infection and treat appropriately. Hepatotoxicity, including drug-induced liver injury, DILI. Hepatotoxicity, including severe, life-threatening, and potentially fatal cases of DILI, can occur in patients treated with BTK inhibitors. Elevations of liver transaminases occurred with WAYRILZ in the ITP clinical trials and were generally mild to moderate in severity. Evaluate bilirubin and transaminases at baseline and as clinically indicated during treatment with WAYRILZ. For patients who develop abnormal liver tests after WAYRILZ, monitor more frequently. If DILI is suspected, withhold WAYRILZ. Upon confirmation of DILI, discontinue WAYRILZ. Embryo-fetal toxicity. Based on findings from preliminary animal reproduction studies, WAYRILZ may cause fetal harm when administered to a pregnant woman. Verify pregnancy status of females of reproductive potential prior to initiating WAYRILZ treatment. Advise females of reproductive potential to use effective contraception while taking WAYRILZ and for 1 week after the final dose. Adverse reactions. Most common adverse reactions reported, incidence of greater than or equal to 10%, were diarrhea, nausea, headache, abdominal pain, and COVID-19. Drug interactions. Avoid concomitant use of WAYRILZ with strong or moderate CYP3A inhibitors, which increases the risk of WAYRILZ adverse reactions. If short-term use of these inhibitors cannot be avoided, interrupt treatment with WAYRILZ. Avoid concomitant use of grapefruit, starfruit, and products containing these fruits, and Seville oranges with WAYRILZ. Avoid concomitant use with a strong or moderate CYP3A inducer, which may reduce WAYRILZ efficacy. Administer the dose of WAYRILZ at least 2 hours before administration of an antacid or histamine H2 receptor antagonist. Avoid concomitant use of proton pump inhibitors with WAYRILZ. Concomitant use of acid-reducing agents may reduce WAYRILZ efficacy. Rilzabrutinib is a moderate inhibitor of CYP3A and increases exposure of these substrates. Monitor for adverse reactions and consider dosage adjustment of the CYP3A substrate. Rilzabrutinib is an inhibitor of PGP, BCRP, and OATP1B in vitro. The effect of concomitant use of WAYRILZ with OATP1B and BCRP substrates has not been established in clinical studies. Monitor for adverse reactions of the concurrently administered PGP, BCRP, or OATP1B substrate more frequently, where minimal substrate concentration changes may lead to serious adverse reactions. Use in specific populations. Lactation. Due to the potential for adverse reactions in a breastfed child, advise lactating women not to breastfeed while taking WAYRILZ, and for at least 1 week after the final dose. Hepatic impairment. Avoid administration of WAYRILZ in patients with moderate or severe hepatic impairment, Child-Pugh Class BC. Renal impairment. Avoid use in patients with severe renal impairment. Please see full prescribing information.